again, M mode is very, very important, not only to help you make a diagnosis, but it appears on all tests. So you have to have a very good understanding of M mode. Again, you have to know normal structures, because once you know what the normal structures look like, you can work out pathology. But they're going to bring just a limited amount of pathology, and once you know those pathology, then you can get almost all of your M mode questions correct. You have to know what aortic stenosis looks like on the M mode, bicuspid aortic valve, aortic regurgitation, mitral stenosis, hypertrophic obstructive cardiomyopathy, left atrial myxoma. You have to know what systolic heart failure looks like, pulmonary hypertension, and pulmonary stenosis and tamponade. So again, it's only a few pathology you have to know, and these are the ones that they're going to put on the test. All right, so let's when we say M mode, the M stands for motion. So it's a motion mode echo. What we have been teaching so far is what we call two-dimensional echo, where you can see length and breadth, so to speak, two-dimensional echo. But this is just a motion mode, okay? Or if you want to call it time motion mode, okay? So there is a time and there is a displacement, okay? So we on the horizontal axis, we have time, and then the vertical axis, we have displacement. It's called the ice pick view of the heart because of how it got started. A pathologist who did a lot of work in this area, what he did, he stick an ice pick in the heart, image it, and then did the pathology to see if it corresponds with what the echo looks like. So that's called the ice pick view. So, for historical purposes, you might see that ice pick view of the heart. Again, the vertical axis is displacement or distance, and the horizontal axis is time. When you do any type of echo, it is gated. That means it's related to the ECG or EKG. So it's whether it's either systolic or diastolic. Okay, and we went over that when we started echo. So systole is from the beginning of the QRS to the end of the T wave, and diastole is from the end of the T wave to the QRS. So M mode, two-dimensional echo, they are gated. One of the first questions you're going to get on your test, all tests, M mode has superior temporal resolution. M mode has superior temporal resolution. What we mean by that, it can detect very rapid motion. So anything that's moving very fast is best to use M mode to look at that structure. So M mode is better to looking at valves because the valves are moving relatively fast. So M mode is better to look at valves than, say, your two-dimensional echo. When you do a two-dimensional echo, the frame rate, and when we do ultrasound physics, you'll understand this a little bit better, but the frame rate, which is the number of frames per second, for the two-dimensional echo is probably 50 to 100 frames per second. So for M mode, we usually use a frame rate of about 50 to 100 frames per second. But for M mode, the frame rate can go as high as 3,000 frames per second. The older M mode that we use, that's started echo, where it was imageless, the frame rate for that was close to 3,000 frames per second. So if it has a higher frame rate, that's what we call temporal resolution. So M mode has a superior temporal resolution, and this appears on all exams. Okay, so the normal M mode echo, when you do a power sternal long axis, and you always currently when we do M mode, it's always 2D guided. It is always 2D guided, and the importance of that is, when you're doing measurements, if you're going to measure using M mode, you have to use 2D guidance because your measurements have to be perpendicular to the structure. Okay, so it has to be 2D guided. All right, so if we're looking at, okay, so these are the first set of normal structures that so first we're going to look at normal structures, and then we're going to look at pathology. So you have your two-dimensional echo on top. This is what you're accustomed to. And this is your parasternal long axis view. Your M mode is on the bottom. Okay? Again, on the vertical axis, you have displacement or distance, and on the horizontal axis, you have time. Okay? And you need to see what the calibrations are. Okay? This is telling you that the calibration is 20 millimeters. So each of these each of these markings are separated by 20 millimeters. So you can calculate thickness and all that sort of stuff. And then the time is on your horizontal axis. So you need to know, what the time is. All right, so let's work through this M mode. So if you look on top here, we have a two-dimensional echo on top, and we'll call this the cursor. The cursor is looking at some structures. So this cursor right here, the first structure it encounters is a chest wall. Okay? The first structure is a chest wall. Then the next structure that it encounters after the chest wall is the pericardium. All right? It encounters the pericardium and then the RV wall. So I mean, if you just think, this transducer is right here. This always depicts the transducer. The transducer is on the patient's chest. Okay, the ultrasound beam first, after travel through the chest wall, it's going to encounter the pericardium, the RV wall, then the RV cavity. Okay, after it passes, so you can see the cursor. You can see the cursor right there. After it crosses the RV cavity, it comes to the septum. After the septum, then it goes to the LV cavity. After the LV cavity, it goes to the posterior wall. And below the posterior wall is the pericardium. Okay? So again, the first structure is the chest wall. Okay? After the chest wall, you have the pericardium. Okay, the pericardium is just outside of the RV wall, the wall of the RV. Then you have the RV cavity. You have the septum. You have the LV cavity and the posterior wall. So again, you have your ECGs on top. Everything is gated. Again, in systole, you can see that the septum moves towards the posterior wall. So the septum and the posterior wall moves towards each other in systole, okay? And then in diastole, they move apart. That's what you expect. So that's a normal function of the heart. In systole, the septum moves down, the posterior wall moves up. In diastole, the posterior wall moves away from the septum. So if you're going to measure the LV, well, if you're going to measure the septum, we usually measure the septum at the onset of the QRS. So you just map where the onset of the QRS, you come down and you measure the septum, okay? You measure the septum. And you measure the septum from the leading edge to the trailing edge. So just the thickness of the septum, okay? You also measure the LV cavity in diastole, okay, at the onset of the QRS. So it's right there to right down there. Okay, so again, in diastole, the septum moves away from the posterior wall because the heart is now filling up with blood. And then in systole, the septum moves towards the posterior wall so they get closer to each other. Okay, so the lowest point of the septum, you're going to drop a perpendicular, and that is going to give you LV cavity in systole. Okay, so this is what the normal M mode at the mid-ventricular level looks like. Okay, all right. So when you measure the septum again, it's at the onset of the QRS, and you measure the thickness of the septum. When you measure the LV dimension in diastole, it's at the onset of the QRS, and you just measure from the septum to the posterior wall, and then the posterior wall measurement is also at the onset of the QRS. You measure the thickness of the posterior wall. Systole, you're going to see where the septum is lowest. Okay, remember in systole, the septum moves towards the posterior wall. You find out where the septum is lowest in its excursion, you drop a perpendicular down to the posterior wall, and that's the LV dimension in systole. Okay. All right, so the next structure that we're going to look at is at the mitral valve level. So you look at your cursor, so you move your cursor from here to across the mitral valve. So the cursor is now here. So your two-dimensional echo is on top. The structures that you're going to encounter is the chest wall first. After the chest wall, the pericardium. After the pericardium, the RV wall. You're going to get a portion of the RV cavity. You're going to get a portion of the septum. You're going to get a little portion of the LV cavity. Then you're going to strike the anterior mitral leaflet first, then the posterior leaflet, and you're going to get a little portion of the left atrium. Okay, so the cursor tells you what structures you're looking at. So two-dimensional echo on top, your M mode echo is on the bottom. So this is the chest wall right here. It's not moving, so it's a straight line. Well, minimal motion. So it's a straight line. Then the pericardium, then the RV wall, Then you have the RV cavity right there, RV cavity. You have the septum, which is right there. The LV cavity is right there. And inside the LV cavity, this is the anterior mitral leaflet. Okay? The mitral valve is open right here. You always have your ECG on top or below. You always have your so so the ECG is either on top or below. The mitral valve opens in diastole. That's at the end of the T wave to the QRS. Mitral valve opens in diastole, and when the mitral valve opens, it looks like this. The mitral valve closes in systole. Okay, this is the anterior mitral leaflet. The posterior leaflet is below, and it's a mirror image of the anterior leaflet, but it's below. So the mitral valve opens in diastole, closes in systole. So you can see it has a M configuration. It has a M configuration, and you have to know what these points are. So there are 1, 2, 3, 4, 5 points, and you have to know what the points mean. Okay, so this is the mitral valve inside of the LV cavity. Below the mitral valve then is the left atrium, okay, and then this is the atrial wall. So just look, so you can know the structures that is in the M mode by looking at the cursor and see where the cursor is crossing. You know, I said the earliest M mode it was not 2D guided. So that is why they had to stick the ice pick, because they're getting these pictures. So imagine you don't know what the 2D, you don't have a 2D, you don't have a two-dimensional echo. This is what you have. So you don't know what this structure is. You know, you don't know that this is the mitral valve. You know, you wouldn't know that this is the mitral valve. You wouldn't know that this is a septum. So that is why they had to stick an ice pick, and then when the image, they say, oh, then this is a septum, because they didn't have this. Okay, so when they went to pathology, they said, oh, the ice pick is in the septum, so this thing here is a septum. And then the same thing for the mitral valve. So, oh, this is the mitral valve. Okay, all right. So the anterior mitral leaflet, the posterior leaflet, which is a mirror image. The mitral valve opens in diastole and closes in systole. Okay. All right. So there are 5 points: the D point, E point, F point, A point, and C point. So you have to know what these stand for. Okay, you'll get them in the exam. So the D point is end systole. So if you just think about it a little bit, as I said, the mitral valve opens in diastole. So the D point have to mean end of systole. Now you're going into diastole where the mitral valve is opening. The E point is the early opening of the mitral valve. The F point is the mid-diastolic closure. Okay, mid-diastolic closure. The A point is atrial systole, when the atrium contracts. And then the C point is closure of the mitral valve. Again, mitral valve opens in diastole. D point represents end systole, so you're going into diastole now. Okay, the mitral valve opens in diastole. E point is the early opening. F point is mid diastolic closure. A point is atrial systole. And the C point is closure of the mitral valve. So you have to know those points. Now the next structure that we're going to look at is the aortic valve. So the cursor now is here. The cursor is across here. Okay, and then just look at the structures that the cursor encounters. The chest wall, of course, the pericardium as usual, a little portion of the RV wall, okay, a little portion of the RV. Then it encounters the aortic wall. The aortic valve is inside the walls of the aorta. Then it encounters the left atrium, and then the wall of the left atrium. So the structures in your M mode: chest wall, not much motion, that's why it looks so straight. Then after the chest wall is the pericardium, very thin, supposed to be very thin pericardium. Then the RV wall, then the RV cavity. So all of this is the RV cavity. Then This bright thick line is the wall of the aorta, aortic wall. So this is one, sorry about that. So this is one wall of the aorta. This is the second wall. Okay, so the aorta, the first wall you encounter, then the second wall. And then the aortic valve is inside the aortic walls. This is the aortic valve. The aortic valve opens in systole. The aortic valve opens in systole and it has this box-like configuration. So the aortic valve opens in systole. Your ECG is always on top or below, and you can just check it. The aortic valve opens in systole and it closes in diastole. It's supposed to be the normal aortic valve is very thin, so it's very thin, and these two lines are usually parallel to each other. So this is one cusp right there. This is another cusp, okay? And this is what we call the closure line. The closure line is supposed to be at the center of the box, okay? So this is what a normal aorta looks like. These are cusps supposed to be very, very thin, okay? And it's a box-like. So this cusp is supposed to be parallel to this one, and this parallel to that. The closure line is supposed to be in the center. So this represents the aortic valve when it's open, aortic valve when it's closed. It's gated. Okay, so when you look at your ECG, this should correspond to systole and this to diastole. And then below you have the left atrial cavity right here, left atrial cavity, and then the wall of the left atrium. All right, so you have to know your structures. You have to know what normal looks like before you can determine what abnormality or pathology looks like. So if you're measuring using M mode, it has to be 2D guided. If it's not 2D guided, you can't use M mode for measurements. Okay? You can measure the left ventricular internal dimension in diastole. That's at the end of diastole. And you're going to do that at the onset of the QRS complex, which I showed you how to do that. So remember, diastole is when the septum and the posterior wall moves away from each other, and it usually represents the largest cavity. Okay, LV in systole is the internal dimension measured at the maximal excursion of the ventricular septum. So when the septum moves as close to the posterior wall as possible, you're going to drop a perpendicular from that to the posterior wall, and then that's the LV systolic internal dimension. For septal thickness, again, it's measured at the onset of the QRS complex, and you're going to measure just the thickness of the. And then the posterior wall, wall thickness is measured at the onset of the QRS as well. So the posterior wall is measured at the onset of QRS. This is supposed to be wall. Okay, the aortic root dimension is also measured at the onset of the QRS. Okay, so you're going to measure the aortic root dimension. So the aortic root would be from one aortic wall to the next aortic wall. Okay, and it's measured at the onset. So they're going to bring this in the exam. As I say, the M mode is of historical importance. So they want to make sure you know everything about M mode. So you have to know what measurements are done at the onset of the QRS, and then the other measurements that you do. The left atrial dimension is measured at end systole, okay, as the largest distance between the posterior aortic wall and the posterior left atrial wall. Okay, so you find out where you have the maximum dimension, and you just measure that. Okay, so it's from the posterior aortic wall and the posterior left atrial wall. All right. Let me just go back, because these measurements, you're going to get them. All right. So these are all the measurements. So at the onset of the QRS, you're going to measure septum, LV dimension in diastole, the posterior wall. You're also going to measure the aortic root at the onset of the QRS. So the only two measurements that you're not going to measure at the onset of the QRS, if you're going to do the LV dimension in systole, you see where the septum drops down to its lowest point, then you drop a perpendicular, and then the left atrial measurement, okay? The left atrial measurement, you essentially find out where the left atrium is largest. So it's probably right here, okay? It should correspond to systole, all right? At the end of the T wave. So you drop from right there down to the posterior wall. That's the left atrial measurement. So you do 4 measurements at the onset of the QRS, and I'm pretty sure those are the ones that they're going to put on the exam. Septal measurement, LV dimension in diastole, posterior wall, and the aortic root. All right, so this is a case of aortic stenosis. So if you remember what I said about what a normal aortic valve looks like, okay, so your cursor is going across these structures. Of course, it encounters the aortic valve. So let's, you have the chest wall, the RV, first you have the pericardium, then the RV wall, RV cavity, okay? This is the aortic wall. So you can see that the wall of the aorta is a little bit thickened, and now you get to the aortic valve. You can see the aortic valve is thickened. This is thickened, okay? And you can see the cusp separation is not as wide as in the normal aortic valve. So the cusp separation is less. You can see that. So this is in systole when the aortic valve opens. In diastole, you can see this thick structure, which is, you didn't expect that. And then the left atrium, you can measure it to see if it's enlarged. So when you look at this compared to what this looks like, you can probably figure out that because this is now thickened, the separation of the cusp is much less. And in diastole, you can see that the aortic valve is very thick. Okay, so if you see this in the exam, one of your answers should be aortic stenosis. Again, okay, so this is a bicuspid aortic valve. So again, the structures, so your cursor is right there. You encounter the chest wall, the pericardium, the RV wall, RV cavity, and then this is the wall of the aorta. You can see the wall of the aorta is thickened, okay? So you can see the wall of the aorta is thickened. The aortic valve is inside the aorta. You see the aortic valve is not very thick, but the closure line. So this is what we call the closure line. The closure line is off-centered. Remember, we say it's supposed to be in the center. You can see this is off-centered. So once you see a closure line which is off-centered, you have to think in terms of bicuspid aortic valve. Okay? All right. Now, when you look at this M mode, okay, structures that, this is the cursor, and the structures that the beam is passing through. Okay, first you have the chest wall, the pericardium, the RV wall, the RV cavity, the septum, LV cavity, and it crosses across the mitral valve. So this is the RV wall right there. The RV cavity is below that. This is the septum. Okay. Um, and this is the posterior wall down here, and then this is the 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 mitral valve. Okay, the mitral valve opens in diastole, closing systole, opens in diastole. Sorry, closing systole, opens in diastole, closing systole, opening diastole. So the ECG is on top. So you should be able to do your points. So your D point will be right there. D point. This is your E point. F point is right there. Okay. This is your A point, C point. What they want you to observe. So this is the anterior mitral leaflet, and the posterior leaflet is below, which is a mirror image. Okay. There's a number of pathology right here, but they just gonna, when they ask this question, they gonna just ask you one of the pathology. They're not, for your exam, probably one of the pathology. They're not gonna ask you all of the pathology. What I want you to look at the anterior leaflet. It's a little bit wavy right there. It's a little wavy right there. And you can see, so what we call this fluttering of the anterior mitral leaflet. When you have severe aortic, look at the heart in the parasternal long axis view. If you have severe aortic regurgitation, blood is going backwards across the aortic valve into the LV cavity. That blood which is regurgitating from the aorta is going to strike the anterior mitral leaflet, and it's going to cause it to flutter. Not only can it cause it to flutter, but you can also get diastolic closure of the mitral valve if you have torrential aortic insufficiency. Because remember, the mitral valve opens in diastole, but you have this blood coming from the aorta and hitting the anterior mitral leaflet, trying to close it. So you can get premature closure. But one of the first things you're going to get is this, what we call the fluttering of the anterior mitral leaflet. So this little wavy thing is the fluttering. This is the fluttering. Okay, and then say you're going to get this. So, fluttering of the anterior mitral leaflet. So you need to know the pathologies. All right. Mitral valve prolapse. So if you have mitral valve prolapse, when we say someone have mitral valve prolapse, what we're saying, in systole, when the mitral valve closes, it bends sort of backwards into the left atrium. That is the definition for mitral valve prolapse. In systole, when the mitral valve closes, it bends backward into the left atrium. All right, so you have your two-dimensional echo on top. Your cursor is crossing these structures here. The first structure it encounters: chest wall, the pericardium, the RV wall, RV cavity, septum, LV cavity, and the mitral valve inside the LV cavity. So these are the structures that is depicted below: chest wall, pericardium, RV cavity. This is the septum, the mitral valve. Mitral valve opens in diastole, closing systole. You can see that this in systole, the mitral valve is now bending into the left atrium. You have to know what your normal MO looks like, and then these things just stands out when you see them. But in systole, ECG is on top, okay? Systole, onset of QRS to the T wave. In systole, you can see the mitral valve bends into the left atrium. Systolic bowing of the anterior mitral leaflet. And you can have diastolic bowing as well. So mitral valve prolapse, okay? All right, so this is mitral stenosis. So cursor is right there, two-dimensional echo is on top. The structures that the cursor passes through, just look, okay? All right, so the first thing it encounters is the chest wall, the pericardium, the RV wall, the RV cavity. The next structure is the septum. Okay. The next structure is the LV cavity with the mitral valve there. So you suppose this is the anterior mitral leaflet, the posterior leaflet is below, and then you're gonna get into the left atrium. Okay. If you look at the mitral valve, this is the mitral valve. So ECG is below. So the mitral valve opens in diastole, closing systole. You can see that the mitral valve is thickened. There is not much separation of the anterior leaflet from the posterior leaflet. And the important thing is the slope. The E to F slope is there's almost no slope. So if your E to F slope is reduced and you have this type of uh, mitral valve configuration in your M mode, this suggests mitral stenosis. Loss of the E to F slope, thickening of the leaflet. Let me just go back to show you what your E to F slope looks like. So this is your E point and your F point. You see that there is a steep drop off. Okay, so this is what we call the E to F slope. In mitral stenosis, that slope is very, very reduced, less of a slope. So you can see the slope, normal E to F slope. Okay, so the mitral valve is thickened, loss of the E to F slope, and the separation of the leaflets are reduced. Okay, so now this, you're definitely going to get this on the exam, so you have to know what it looks like. So all you do, you just work it out. So don't get flustered. That's the worst thing to do, is get flustered. From first principles, your two-dimensional echo is on top. These are the structures that the cursor passes through: chest wall, pericardium, RV wall, RV, septum, LV cavity, mitral valve, posterior wall. So these are the same structures. You can see chest wall, the pericardium, the RV wall is right there, RV cavity. The septum is a bit thickened. You can see that. You have to know what normal looks like to determine what abnormality is. Okay, you can see they give you the scale. So each of these little marking is one. Each of these marking is 1 centimeter. So you can measure. This septum is very thick. Okay. All right. So you have the mitral valve inside the LV cavity down here. You have your ECG there. They didn't put ECG for cosmetics, so they put the ECG. So you use the ECG. All right. So systole is from here to there. So you have something going on in systole right there. Diastole is from right there to there. We know the mitral valve opens in diastole. So diastole is from right there to there. The mitral valve opens in diastole. Mitral valve open. So these are mitral valve opening, mitral valve opening, mitral valve opening. So there are a few things going on. We have our E point. We don't have much of a F point. There's a little A point. Okay, but in systole, there's something going on in systole. Okay, so diastole, mitral valve open. In systole, something is going on in systole. If you look carefully, you can see that there's systolic motion of the mitral valve towards the septum, motion of the systolic mitral valve towards the septum. This is what we call SAM, and you're going to get it. This is SAM. It appears in all exams. SAM, systolic anterior motion of the mitral valve. Systolic anterior motion of the mitral valve. The mitral valve hits against the septum. Okay? And you get that in hypertrophic obstructive cardiomyopathy. SAM, systolic anterior motion of the mitral valve. You see it impinges against the septum. The septum is thickened, the posterior wall is thickened, and that is why it's hypertrophic Cardiomyopathy, it is obstructive because you have SAM, systolic anterior motion of the mitral valve. Okay, so the septum is thickened, posterior wall is thickened, mitral valve opens okay, but there is SAM, systolic anterior motion. Okay, so you're also going to get this. They like it for whatever reason. Okay, so again, same work from first principles, two-dimensional echo on top, cursor is right there, cursor is crossing these structures. So you see the chest wall, the pericardium, RV wall, RV cavity, septum, LV cavity with the mitral valve, a little portion of the left atrium. So these are the same structures that you're going to see down here. The chest wall, the pericardium, RV cavity, septum, this is the septum, the LV cavity with the mitral valve, okay? This is the anterior leaflet, posterior leaflet should be someplace down there, okay? The mitral valve opens in diastole. Just look for your ECG, it's gonna be someplace, okay? Systole is from there to there, diastole is from there to there. The mitral valve opens. Whenever the mitral valve opens, you can see something inside there. There's something inside the mitral valve when it opens, and this is what we call a myxoma, okay? It's a tumor that's trying to get out of the heart, get out of the left atrium. When the mitral valve opens, this thing protrudes through the mitral valve, trying to get out of the left atrium into the left ventricle. So in diastole, when the mitral valve opens, you can see this mass. In systole, the mitral valve closes, in diastole it opens, and this structure is a mass trying to get out of the left atrium. It's a myxoma, most likely myxoma. They always bring it on your exam. All right. The next abnormal structure pathology is systolic heart failure with reduced ejection fraction. And if you look carefully, always work from first principles. I mean, some of these things you can do once you look on it. If you're seeing enough, you can quickly identify it and move on. But if you have difficulty, work from first principles, two-dimensional echo on top, cursor is right there. The cursor passes through these structures, okay? So you have the chest wall, the pericardium, RV wall, RV cavity, septum, LV cavity, post on the left atrium. So these are the structures. We're interested in the mitral valve. You can see that the mitral valve opens right here. Mitral valve opens in diastole, closing systole. Just look for your ECG. Okay, so everything means something. Look for your ECG. Mitral valve opens in diastole, closing systole, opens in diastole, closing systole. You can see the D point. D point is right there. E point is right there. F point, A point, C point. So this is normal opening. The anterior leaflet is up there. Posterior leaflet is below, mirror image. The important thing, this is the septum right there. We talk about an E point septal separation. E point septal separation. So again, this is your E point, your septum. Your E point septal separation can tell you about the ejection fraction of the heart. It tells you the ejection fraction of the heart, how well the heart is contracting. E point septal separation greater than 1 centimeter is abnormal. The E point septal separation should be less than 1 centimeter. So all you have to do is measure from the E point to the septum. If it's less than 1 centimeter, then it's normal. If it's greater than 1 centimeter, it's abnormal. Okay? Greater than 1 centimeter suggests that you have reduced ejection fraction. Reduce ejection fraction. So, okay, so E point E-point septal separation. E-point septal separation. So again, if you look at this M-mode, two-dimensional echo on top, cursors crossing through these structures. Again, the structures the ultrasound beam is looking at is the chest wall, pericardium, RV wall, septum, LV cavity with the mitral valve, okay, and either the posterior wall of the LV cavity or the left atrium. So the same structures, and all you have to do is just look at the structures in the M mode. So one of the things you're going to measure your E-point septal separation, E-point septal separation, E-point septal separation. If it's more than 1 centimeter, you have reduced ejection fraction. But you're going to go through, the septum may be a little bit thickened, the posterior wall may be a little bit thickened, but look at your points, okay? So we have, this is our E point, F point, A point, and then we have this little bump right there. So let's go over. Your D point is right there, your E point, F point, A point, then there's this little bump. This is what we call a B bump. A B bump tell you that there's increased left ventricular filling pressures, and you usually get that in patients with systolic heart failure. Okay, so B bump usually suggests elevated left ventricular filling pressures and heart failure. Okay, so if you don't readily recognize something, just go through the first principles and you can and you will recognize these things. All right, so we should have shown you what the normal M mode across the pulmonic valve looks like. So your normal M mode across the pulmonic valve, and when you do your M mode across the pulmonic valve, you're just going to see it's just one of the valve. You can't get both valves together. You're just going to get one of the valves, and it will look something like this. This is what we call your A wave. Okay, it will look something like this, A wave. In pulmonary hypertension, you get what we call a flying Doppler. There is loss. You're going to lose your A wave. Okay, so this A wave right here, you're going to lose it. All right. So you're going to lose your A wave. So if they're going to give it to you, they're going to, it will look almost flat, and they will probably give you something. So for pulmonary hypertension, you're going to lose your A wave. Whereas in pulmonary stenosis, you get a very prominent A wave. The A wave becomes very prominent, and they talk about a flying Doppler. So this now look like a Doppler. You can see it look like a Doppler. So they talk about a flying Doppler because the A wave in pulmonary stenosis is very prominent. So it's the opposite to what you'd get in pulmonary hypertension. Okay, so pulmonary hypertension, you're going to lose your A wave, whereas in pulmonary stenosis, you get a very prominent A wave and you get this so-called flying Doppler. See, it looks like a Doppler. All right, so the next thing we're going to look at is tamponade. So, those of you guys who work with me, I always say, did you do your M mode? Did you do your M mode? Because it can help you in determining if tamponade is present, yes or no. So if you take this two-dimensional echo on top and your cursor is across there, you know the structures that you're going to get. The cursor crosses across these structures. So you can just work it out from your MO, the chest wall, or the pericardium, RV wall, RV cavity, um, the, the, the RV cavity. Then you encounter your so first, no, the first thing you encounter, this is your pericardium right here. Then there's fluid in the pericardium. This is fluid in the pericardium. This is actually the RV wall. This is the wall of the RV. So this is the RV wall. And then this is the RV cavity right there. So let's look again. All right, so the cursor is coming down here. The first thing is the chest wall. So, the chest wall. Chest wall doesn't, it's, going to get a series of straight line because there's not much motion. Then this, below the chest wall, you're going to have the first structure is the pericardium. So you have a thin layer of pericardium right there, thin layer of pericardium. Then below the pericardium, you see a fluid. Okay, if you look up here, you see a thin layer of fluid. So that is this fluid that you're seeing here. This is pericardial effusion, pericardial fluid. Then below the fluid is the RV wall. So this is actually the RV wall. RV wall. Below the RV wall, you have the RV cavity. So this is the RV cavity. Then you come to the aorta. So one wall of the aorta, second wall of the aorta, okay? Inside the aorta, you have the aortic valve. So again, the aortic valve, thin structures, parallel, closure line in the center, opens in systole, closing diastole. This is another portion of the aortic wall. Then the left atrium is down here, your left atrial wall. The important thing is to see there's a periodic downshift in the RV wall, periodic downshift in the RV wall, downshift. When we talk about the echo definition of cardiac tamponade is when you get what we call diastolic collapse of the right atrium or the right ventricle. So you have to know the definition. The definition for cardiac tamponade, echo cardiac tamponade, is diastolic collapse of the or right atrium or the right ventricle. So we have this periodic collapse then of the RV wall, but is this in diastole or systole? There's periodic collapse of the RV wall. Is this in diastole or systole? You have an ECG on top. So this ECG is very lousy, so you might not be sure what's going on, but you have your nice aorta and your aortic valve opening and closing below that. The aortic valve only opens in systole and closing diastole. Aortic valve only opens in systole, closing. It can't do anything. It cannot do otherwise, right? Normal aortic valve opens in systole, closing diastole. Opens in systole, closing diastole. So if you look closely, you can see that these collapse are diastolic collapse. Diastolic collapse, diastolic collapse, diastolic. And that's the definition of echo cardiac tamponade. Diastolic collapse of the right atrium or the right ventricle. So your M mode is very, very helpful in tamponade. You get diastolic collapse of the right ventricle. So if you know these things, you can get almost all the M mode correct answers for your M mode questions.